Welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me today is Dr. Justin Lewis and Dr. Jon Harned. The three of us are going to be discussing ankle sprains. So, what is an ankle sprain in the first place? What types of ankle sprains? What are some of the differential diagnosis considerations? Some examination evaluation considerations? How we approach them from a rehab standpoint? How Justin approaches them from an imaging standpoint and even a surgical standpoint, and so much more. So a lot of great information about one of the most common, if not the most common, sports-related injuries today. This episode and every episode in season 5 is brought to you by Isophit. They're my go-to for all things isometric strength training. For more on that, you can check the description below. Enjoy. Justin, Jon, super excited to have you both on the podcast today. Thank you so much for being here, guys.
Thanks for having me, and thanks for having us. Super excited to get it rolling.
Yeah, for sure. For people who might not be familiar with the two of you, would you mind filling them in a bit about who you are and all the amazing things you do?
Yeah, so Justin Lewis, I am a podiatrist. Let's see, I did most of my training in Florida, did a residency down there, foot and ankle surgery. Treat a lot of athletes, all sports, dancers are a little niche that I do as well. Practice in Maryland, another office in Pennsylvania, and yeah, always, trying to learn more. And I've always had that established relationship with PTs based on my background, which was exercise physiology, getting my bachelor's and master's in exercise science. So the whole muscle physiology, muscle tendon unit, the neuromuscular stimulation, all that stuff was some of my core. And so I've always had a high respect for physical therapists, especially since they're the ones taking over care a lot of times for our patients with injuries and surgeries. So I always try to keep that strong relationship with my therapists.
My name is Jon Harned. I'm a sports physical therapist in Maryland as well. I currently work for True Sports Physical Therapy. I'm a regional director here, so I run 4 of our current locations located in the Eldersburg area, Woodbine, Columbia, and Frederick. Been here for 4 years now. I graduated from Lebanon Valley College, PT school in 2020. My undergrad was 2018. Been down here ever since. I took a little different route. The reason I moved to Maryland in the first place was I got accepted into the Johns Hopkins sports residency. Unfortunately, that was during COVID year, so I moved down in June of 2020. And with all the changes of that and being on lockdown and what I was going to, get out of the program originally versus during COVID times, I decided to politely turn down the offer and take a different route. So for me, that has made a massive difference in my career and stuff like that. Just from mentorship in general and, how I've seen myself progress, on a clinical side of things, but also from that leadership standpoint. Being down in Maryland, we, treat so many high-level athletes, and, you too, Dan, being on the Eastern Shore. So you get a sense of that from high school, college, to even on the professional level. So, like Justin said, being able to have those, core relationships with docs, it goes hand in hand, and it truly helps the patient, progress. Being able to have quick and concise communication, that's pretty much right away, whether you got to get somebody in or, just how they're progressing in general.
Yeah, I completely agree with everything you both shared there. I mean, plain and simple, we need to be collaborative in how we manage the care of all of our patients, but especially when it comes to athletes, a lot of times they present with complex injuries that our understanding of has evolved over the past several years. And maybe the way we treat them looks different now than the way we treated them 5 years ago or 10 years ago. And I say that realizing that, 5-10 years ago, guys like Harned and I, we were back in like high school, college days. We might have experienced something like, a sprained ankle, and we might have been told, oh, just ice it a day or two, and, you'll be able to pick back up and go in, the next day, or sometimes even the same day. And that's an area where I feel like our understanding has really evolved over the past several years. And at least for the way I treat ankle sprains, they look a little different now than I went through and experienced myself when I was in high school and college. For the people who might not be familiar with like what defines that term ankle sprain, or what exactly it is, or the subtypes of it. Would you mind kind of breaking that down a little bit more for them?
Yeah, so you're right with the term ankle sprain. And whenever I have patients come in with an ankle sprain, I always tell them, well, if it's and I always do the quotes, an ankle sprain, this is what we can do. But of course, then you have to make sure that it's not your typical ankle sprain. But in layman's terms, we talk about, different structures in the ankle, but usually the lateral ankle ligaments we're always focusing on. And when people, I believe it's the most common sports injury from what I remember is an ankle sprain, right? So, for us, for podiatrists, foot and ankle people, they're coming to our office. I mean, we have to know about them. The funny thing is, a lot of us, I don't think we stay up to date with the research on it. But, we know the anatomy, we know how to evaluate it, but we were looking at the lateral ankle ligaments. Then you're looking at, medial side injury, which is the deltoid ligament. You're also looking at a high ankle sprain, which we call it, but you hear about, on TV all the time because of the NFL players, which is a tibia fibula syndesmosis sprain. So those are generically what we term, say as ankle sprains.
Yeah, I mean, pretty much hit the nail on the head there. I think to go off of that, I mean, a lot of the times, and for layman's terms, like you'll get your typical high school athlete in saying they rolled their ankle and stuff like that. And I mean, making sure like we know the anatomy of what's going on and the mechanism of injury, because that's how we're going to treat it differently from, in the doctor's office versus then, into PT and things like that, and how we're going to progress, accordingly and stuff like that. Obviously, I like to say pain is our guide, but we also have to understand tissue healing times and stuff like that with certain structures and grades. And that's going to be all dependent on what type of ankle sprain, we're dealing with and the mechanism and severity.
I love those points. I mean, plain and simple, the mechanism alone, at least for me, what I usually see is the down and in, that classic plantar flexion and inversion type of injury. And usually when I see that, my mind goes right to lateral ankle. And it's funny because I feel like every time I see it, I jump to like three things right away. I love my little anterior drawer, just grab and pull forward a little bit. I also love my little stress test as we pull it in. And I've noticed a lot of tenderness isolated over ATFL with that kind of common like ankle roll type injury that we typically see. So I think at least from the lateral ankle side, if it's that very common ATFL type of sprain, that's usually what I see. But to your point, sometimes we can injure other regions, or maybe it's more than just the ATFL. Maybe we get CFL involvement, PTFL involvement. And when it comes to differentiating on those ligamentous involvement type things, I think that's where the conversation about mechanism becomes far more important. And the conversation about testing and thorough examination becomes far more important as well. How do the two of you like to differentiate on the lateral ankle versus medial versus high ankle sprain, and even some of the other things that we might see, present similarly to a lateral ankle sprain?
Yeah. So there's always getting the history, right? When the patient comes in, and before you even touch them, it's well, what happened? The unfortunate thing is with sports, with high level, high speed, sometimes the athlete can't even remember, right? The slide tackle with soccer, who knows how the foot twisted or turned? Sometimes you see it on video all the time on the NFL, with certain people getting their sprains. But yeah, knowing the mechanism of injury, if they know it, is important, because it does kind of steer you toward one way, right? If they remember the foot planted and they rotated and twisted, if you have a rotation injury, then you have to think about your syndesmosis. If it's just this classic, plantar flexion inversion, then you can kind of gear towards the ATFL there. Recently had a patient where she stepped in a hole and she remembers her ankle going both ways. And so of course when we did the workup, she had both sides that were injured. But if we would have assumed it was just an inversion injury, then I would just focus on the lateral side. But she had a lot of tenderness on the medial side. So yeah, mechanism of injury important. If the patient can recall that injury, But even if they can't, if they don't even remember, yeah, you do the full workup, right? You're going to palpate all the way down the fibula. For me, I like to palpate bone first, because to me, that's the most worrisome part, palpating the bone, lateral malleolus, medial malleolus, coming up high into the fibula shaft, even to the head of the fibula is important with some of these pronation and external rotation injuries. From there, I'll go into the ATFL. If the bone looks okay, I'll actually palpate the ATFL. I'll push right in there. We'll palpate that, see if we elicit a response. I always go for the fifth Met base. Many times we have seen an inversion ankle sprain, and we had one college athlete, I remember, and he got misdiagnosed and he stepped in a hole. We took x-rays of the foot with the ankle, and it showed a fifth Met base fracture, so he had a Jones fracture. So palpating the fifth Met, perineals, palpating the perineals, posterior side, usually what I do, and then of course the deltoid medial side.
You mentioned the base of the fifth Met there, Justin. They call that like a dancer's fracture, I believe, correct?
Yeah, different types. Dancers fractions, usually an avulsion fracture. We see a lot in dancers because they're always on the balls of their feet. A lot of inversion injuries there, but the peroneus brevis is pulling and pulling. Sometimes it'll crack that bone, and then you'll get a dancer's fracture. Jones fracture, a little bit different mechanism, a little bit higher, more distal from the base of the fifth metatarsal. Still at the base, but just a little bit more distal than a dancer's fracture. And Jones fractures we see as well, which you hear about a lot with, I think Kevin Durant had like 4 surgeries for his Jones fracture. It's just problematic injury. But you can't, the key is, we look at everything, right? We try not to get tunnel vision, and we should be palpating common injuries from those inversion type of injuries. And the other one is the osteochondral defect lesions that can occur as well, which it's hard to really palpate and assess those, but we can get to that later.
Yeah, no, for sure. Jon, outside of the palpation that Justin just outlined and the overall examination, is there anything else that you like to look at yourself when these come in to see you?
What he was mentioning in the beginning with like your palpation, your history and stuff like that, and like ruling things out, like midfoot fracture or like your Ottawa ankle rules. Like for me, and especially if they don't know, it's like going through our basic tests and examination, like kind of like you talked about with our anterior drawer, our inversion stress test. Maybe we're doing an eversion stress test if they had a medial ankle sprain or through the deltoid ligament, which is, I think, sort of towards the the end of like a frequency or occurrence if we're going lateral high ankle sprain. And then that if all that checks out, like, and we're finding it, whether it's a low grade high ankle sprain or a low grade anterior or lateral ankle sprain, I also like to kind of ask within my exam is like, has this happened before? I feel like especially in our younger athletic population, we tend to downplay a severity of an ankle sprain. So maybe it happens once and it's like, oh yeah, like stepped wrong, felt that, and give it a couple days, but then we don't do anything for it and it happens continuously more. And now you have 3 ankle sprains, 4 ankle sprains that aren't going treated and stuff like that. But now we have an issue where we have chronic ankle instability. And especially if we have like those repeat lateral ankle sprains, now what is the integrity and the strength of those lateral structures? What are they looking like? How lax are they? Because then that becomes an issue over time. And you get more of that, with your exam and stuff like that. Because a lot of times if you don't ask that, that's not going to come up. And especially, with your high level field athletes and just in general, and, being in Maryland, especially with lacrosse, I'll have a boy or a girl and they're like, yeah, this is like the 6th time I've rolled it. And I'm like, did we do anything before? Like, no, just kind of like went out, like maybe braced it up. And we can get into that conversation, down, later, but like bracing and stuff like that. Because that sometimes has an issue, depending on if we're just bracing and not doing other things. So besides all what Justin hit, making sure we're assessing, the right structures, ruling other things out to avoid these misdiagnoses, and trying to get the big picture and stuff like that. I mean, there's always the idea of like looking up the chain and stuff like that. But I think like on that eval, you're going to go for that lowest hanging fruit. That patient's coming in pain. We know it's an ankle sprain based on our test. Now how we can address that moving forward and rule out appropriate structures, and then down the road get into the nitty gritty stuff.
Definitely. I love that point, especially bringing up the CAI conversation as well, because it gets a lot harder to treat one of these when it's happened 8 times, 9 times, 10 times, and you're looking at a 16-year-old, right? Like it's crazy the difference that you feel side to side from the ankle when someone's rolled it 8, 9, 10 times over, like never rolled it before. And the impact that has not just on sport, but even daily life can be pronounced, right? Like, someone comes in and they're like, yeah, it happened 2 weeks ago. This is the 8th time, but now I'm just having issues just going about my day to day, like walking. Like, it's crazy how sometimes we become so hyper fixated on the sport that we forget some of the simple things that people kind of need to do on the day to day, athletes included. I'm curious too. We talked a little bit about the examination. Jon, when do you go about referring to someone like Justin when you start treating someone or examine someone after one of these injuries? And Justin, when do you go about like ordering more advanced imaging? Like, what's your cut or threshold for like X-ray, MRI, that sort of thing for one of these?
So on my end, when I'm doing my exam, getting all of the information we discussed, it's going to be based on like how are they presenting. Like if I'm doing my testing, how much gapping do I have, or how much joint play do I have? And that's all in relation to like, when did they come to me? Like, did they come to me 2 weeks down the road and it's still super bad, or is this like super fresh? So how much laxity do we have? How much tenderness, how much swelling? Am I suspicious of, a potential, fracture or midfoot fracture? And that's when you do your auto ankle rules, things like that, as well as like I'll worry about a tuning fork, just to be safe. Now if that starts coming back a little like inconclusive, I'm not sure and stuff like that, or I definitely know, I'd hit up Justin and be like, hey, I got this athlete, I just want to take a look, rule things out just in case. I don't think you're doing that athlete a disservice by doing that if there's like a red flag, or you're questioning it. Rather to be safe than sorry on that end, depending on their severity and how they're walking in and things like that, and just doing our due diligence, because just like Justin's story, we don't want to go 3 weeks down the road, 4 weeks down the road, they have maybe a potential fracture or a complete tear, and now it's like, well, we just missed that window, and now we potentially made things worse and stuff like that. Or, right, like especially with like the revolving, time of play down here with things going on, maybe we had a good window to treat, and now this athlete's in tournament, but now we just missed that because we're unsure and stuff like that. So it's never a bad thing to get extra imaging if you have questions, if something coming back hairy or inconclusive and stuff like that. Now I will say, swelling obviously plays a big factor depending on the swelling, and things can come back a little different. So if it's super fresh, you can always get the swelling down, revisit in 2 or 3 days. And then if it's still, just, send a Justin, send to a doc just to get a workup.
Yeah. For me, like, I get x-rays on all of them. I know the Ottawa ankle foot rules. I just like to get x-rays, and I get it, when it started, but when it started in Canada, and the whole point was, it's socialized medicine up there. Cost savings are a thing, right? And yeah, do you have to x-ray everyone? Not necessarily, but the financial burden, in the office, I get paid $30 from insurance to get an x-ray. Like, it's not like I get $500 and I'm bankrupting the system. So from my peace of mind, I like it, because I like to look for avulsion fractures. I like, sometimes you can see an osteochondral defect right away. But having said that, everything's normal. You think it's an ankle sprain. My generic rule of thumb is 4 weeks, right? In 4 weeks, the majority of people should be significantly better, right? And after 4 weeks, I tell patients that, we've all sprained our ankles. I've done it. I've done the countdown. I've been like, it's 4 weeks, man. I still feel something here. And I'm not, even for me, I'm like, oh, let me give it a little bit more time. And then 6 weeks will go by. And for me, I think it was a perineal that was a little aggravated. It took me 8 weeks for that to go away. But I always say 4 weeks. but after 4 weeks, if patients aren't significantly better and they're still like, I don't know, it's just, and then you start, doing a further examination and maybe the swelling's gone down and you can do more detailed things. I'll usually do an MRI. Yeah, I'll do an MRI just so I can look. And again, recently we had a patient, she's strength coach, CSCS, chronic ankle instability, Cavus foot type, has had frequent ankle sprains, and this one was just a little different, and bone marrow edema, right? So it was bone bruising, like fibula talus. And that's a painful thing as well. Like no fractures, bone marrow edema, just the pressure built up, and we had to treat it like a fracture and just boot her up and just immobilize and let all that bone marrow edema go down. But we needed that MRI to evaluate that. So usually 4 weeks is what I would say for advanced imaging. But yeah, I rarely do advanced imaging like right away.
Yeah, no, for sure. You made a interesting comment there in that case that you just presented where you said, we had to treat it like a fracture. We had to boot it up and all that. And it's funny because I've seen several patients come to see me after an ankle sprain in a cam boot. And they're like, well, I was told to wear this. And some of them come in with a lace up and they're like, well, I was told to wear this. And some of them come in with nothing at all. So when it comes to the boot, the brace versus nothing, or, I'll throw another one out there. There's some I've seen that just kind of like chronically tape their ankles, for lack of a better way to put it. And they just live with tape, almost like duct taping the thing stable. For lack of a better way to put it, when it comes to like that whole like external fixation, stability type structure, immobilizer, whatever you want to call it, what exactly is that doing for us in the ligamentous sprain or high ankle sprain world? And is there any merit to any of those things in either of your opinions?
I'll touch base a little bit. I think Jon is probably better to talk about that. But going back a little bit, you asked Jon, at what point do you feel like you should refer to Justin? But sometimes it's the other way around. Like, at what point does the doctor say, no, we need to refer to PT? Because there are many times where the doctors hold the sprain way too long, or the doctor evaluates the sprain on a high-level athlete and says, just give it 4 weeks in the boot, and then you'll be good. And, put some ice on it. And we know that's not, now we know it, that's not ideal. But as far as booting it, embracing it, et cetera, usually when I see an ankle sprain, many times they come in 1 week after the injury. Because it's sometimes it's hard to get in and see the doctor, and a lot of times the parents are afraid that there's something broken. They'll take them to urgent care and they'll get the X-ray there, or they'll take them to the ER, get X-ray there, and then the urgent care or the ED will give them a boot. Sometimes they'll put them in a splint, right? And crutches, and they say, just try not to walk on it, follow with your specialist. And usually I'll see them 1 week later, right? Well, after a week, if it's a grade 1, 2, if it's a sprain, we know those phases of healing, right? The inflammatory phase, the repair phase, the remodeling phase. But that initial phase with all the inflammation, what do they say? 1 to 5 days, 1 to 6 days, roughly a week, right? So after a week, that inflammatory phase is pretty much done. And at that point, the question is, well, do you need a boot, right? And there's a lot of literature on that. Do you need a boot for 4 weeks and then go see PT? No. Like we know that. I mean, but the thing is, that. A lot of doctors still don't know that. I mean, because we're not getting inundated with this physical therapy research, this athletic training research. We don't, in our inbox is always surgery, pathology, fracture management, but we don't get a lot of the sports med research and literature. So there are some of us that still like say, immobilize. And there's always that debate amongst us, and surgeons and specialists. Do you do early rehab or do you wait that 4 weeks, right? And now I don't think there is a debate, right? We know functional rehab leads to better outcomes, and to do things early, and you can talk about that later about how you stage and progress your algorithm. But, 1 week of immobilization is most people is, yeah, that's it. Those first few days, rest, ice, anti-inflammatory, immobilize with a boot, whatever you want. And then if you're a high-level athlete, let the therapist take over, right? PT needs to just take over and get everything going. As far as the lace-ups, the ankle sleeves, I'll let John touch base on all that, because I think there's even some debate on some of those things too.
Yeah, I mean, this question is always a double-edged sword, right? Because there's a lot of factors that come into play. Like, obviously, with like your cam boots and stuff like that, I've seen that with more high severity, high ankle sprains. For obvious reasons, like splaying, like that's a syndesmotic membrane and things like that. So that may be more beneficial in a certain period of time. For your standard lateral ankle sprain, which occurs all the time, and for your grades 1 and grades 2, I'm not a major fan of a brace per se, because if they're able to walk right with minimal discomfort and stuff like that, that's going to help promote just early ankle range of motion, early loading in positions that not necessarily straining that ligament, but it's also going to help get that swelling out, right, with our calf pump and things like that. Now, it's one thing if they're in excruciating pain, then it's a different story. But if their pain is low level, we can probably start doing that. We know we can start doing that, because that's also going to kickstart all of our healing processes, and we're going to be able to move forward in rehab. If you lock that thing up right away in a brace, like we're worried about just stiff ankles at that point. We know one of like the risk factors for increased lateral ankle sprains, other than our strength and stuff like that, is just poor dorsiflexion range of motion. So if we have a kid who's chronically taping and stuff like that, and some of them do it because they like it's just what they do. Like you see it in football, taping the ankles and stuff like that, or even like some of our lacrosse kids we treat, and it's just like, oh well, do your ankles hurt? No, I just tape them. Those are the guys that have such bad ankle range of motion. The second you take them out of that, they're screwed. They're gonna roll. They have stiff ankles and stuff like that, because all of those structures around get weaker. Not only in the ligaments, stuff like that, but your calf musculature and things like that, because you're just in a fixed position, right? It also is going to impact just general proper function, whether be Achilles tendon, calf musculature, appropriate shin angles for sprinting, and being able to have that knee over our toe when we change direction and cut and things like that, which is then going to just go up the chain and affect the knee. So I think if we're able to like load with discomfort and begin walking, I'm not a huge fan of early bracing. Now, then there's also the debate of someone doing it in season and trying to make it through the season, and how do we get them just to appropriately make it through the season if their pain levels are well managed and things like that. That's a different topic. Maybe we brace while doing PT, but for your standard ankle sprain, they're taking some time off. We're going to rehab this thing and get you back. I'm not a huge fan of bracing early on.
Yeah, I love those points, and I completely echo all of those. I mean, to me, in my mind, if I brace or immobilize something, then not only am I teaching a way to move without movement at the foot and ankle, but I'm also doing a huge disservice to the tendons in the area. I think a lot of people forget about tendinopathies until it happens to them, right? Like until you get that 21-year-old college basketball player who comes in after he blew his Achilles. And it's like, well, you're too young for this to happen to you. But it's like, we look back at the history and it's like, oh, wow, we had a lot of periods of immobilization. We had a lot of other things, and we never actually adequately loaded the tendon to support it, right? So I certainly echo that point from a ligamentous standpoint, but also from a future injury standpoint as well, right? Like, we can't put someone in a boot for 4 to 6 weeks and then take them out and think that everything is going to magically work normal. That's just not how the body works. So I completely echo that point. And, to your point too, on the just ankle range of motion, right? Like getting that back is absolutely essential. And when I test that dorsiflexion, I actually like to hold them in a subtalar neutral position. And if I don't, it's crazy to see the difference. But that difference comes from a lot of times they start to move the subtalar joint into a position I don't necessarily want them to go into. And if I hold them neutral, all of a sudden our talocrural joint, TC joint, dorsiflexion is like half of it. So it's crazy to see the ways that athletes will compensate in order to get this more motion. But to your point, if we let that go unchecked, then it might happen again, and we might see him again, 6 or 8 weeks later with the same injury, and that's what we're trying to prevent here after all.
Yeah, I'm actually a fan of ankle sleeves. It still gives motion, right? It still allows for motion, a little compression for some edema, but the main thing that we like also is that proprioceptive response, right? So, the question with all those braces and there's debate on that, like what's superior. And is it the proprioceptive response from the brace, or is it the mechanical construct? And if you have rigid ankle braces, yeah, I think you're hurting more things than helping. But could you get the same proprioceptive response from an ankle sleeve, just a neoprene sleeve, which is simple? It slides on. The other thing is shoe gear, right? I mean, some of these there's no way you can fit into a cleat or a shoe, or I know they have these external braces now, but ankle sleeves, I've told athletes to use them to wear them if they need to give them that little sense of security. And then who knows what that proprioceptive actual mechanism is. I don't, but I know that the research has shown that.
We have tubular sleeves in clinic, and we use a lot of just like ACLs and swelling and stuff like that, but we will cut them for ankles as well, just to help flush some of that out and add some sort of compression and stuff like that. Because you're right, that's not going to impact the range of motion because it's so thin and stuff like that. Easy thing for that athlete to start wearing that's going to kind of just start speeding things up.
Yeah, no, that's a great point. I like that a lot too. As far as actually progressing them back from when they come to see you from injury to when they go back to sport or activity or whatever they're trying to get back to, you mentioned before, Justin, about, usually a minimum 4-week timeline. It should be feeling a lot better. What does the actual progression look like for you from a rehab standpoint, John? And, how does that change at all based on what's involved or the timelines of structures, that sort of thing?
I mean, obviously with anything, like if it's a higher severity, it's most likely going to take longer, right? Like your higher ankle sprains are going to take probably roughly twice as long, maybe compared to like your lateral ankle sprain, just because of like this, the splaying of that tib fib joint. And, that's a little bit more severe, as well as like your medial ankle sprain. In terms of like just, general progression, I think like you got to just make sure like you crush your basics really well. If you don't have a super strong foundation, you're not going to be able to build upon anything, especially when you get into that return to sport phase of sprinting, cutting, force production, deceleration, being able to change direction, like RSI type stuff. So early on, obviously you're protecting the structures involved. So if we're talking about a lateral ankle sprain, protecting the structures involved, working on early range of motion, getting that back, as well as like building basic, minimum strength, plantar flexion strength, but also getting that person out of that plantar flexion and inversion position. A lot of time I'll see, you can just have them lay on the table. That affected ankle is just going to flop in the plantar flexion inversion, especially if you see somebody with repeat ankle sprains. So working on getting, at them out of that position, and that's super basic stuff you can do on a table or with a band, like early on, depending on severity. So that's just like your dorsiflexion, eversion type stuff. But once you're out of that early on window and you're building strength, I mean, you can be as creative as you want to be, loading the foot and things like that, as well as like from a balance standpoint. And that doesn't just include our foam pads, which we like to talk about. Like here at True Sports, I'm sure, other clinics may, call the same thing or adopt it. You can add heel floats to different various positions. So kind of going up in a slightly plantar flex position, whether you're doing a squat, a lunge, like RDL hanging off a plate, just to get kind of more foot activation going. But also you then want to put that person in that position of plantar flexion and inversion so they can learn how to not fall into that position. So slant boards are huge for us. And putting that person or that athlete in that position to be able to kind of come out of it and know what that's like. So I feel like if you're never strengthening in that position or in that area, the likelihood of that coming back is high. So crushing your basics, building your basic strength foundation. Obviously, like we have testing and things like that, with force plates and Tindex and stuff like that. But also making sure that they're able to pass what I like to call a look test during our strengthening standpoint. Does it look clean? Does the movement look clean? Are they having pain? are they able to progress from your basic isos to eccentrics to concentric contractions? Can they do it fast? Adding all your variability with your landings, your jumps in various planes, and things like that.
Yeah, it's a very progressive rehab approach. It's not just sit on the table, ice, massage, 3 sets of 10, four-way ankle, and call it a day.
No. And I think like it's right under, like, if you can understand the basics, it's a super simple process, and it's not like rocket science. And I don't mean that in a bad way, right? It's get our swelling down, get our pain down, improve range of motion. If there's a deficit, increase strength, and then slowly check off those buckets and fill those buckets to the next thing. The biggest thing, if you're going to have issues with, if you progress way too fast and you skip some few steps, and or they're just not strong.
Yeah.
So I have a question. I have a question then for both of you, I guess. So take me through it, John. You have the ankle sprain. It's you.
Yeah.
You treat the patient, not whatever the protocol, and it should be individualized. We know you. You don't play college baseball anymore, but you're still high level active, right? So you have that patient come in. It's a grade 2 partial tear ATFL, swollen first week. What do you do at week 2 for PT, week 3, week 4, 5, 6? How does that progress? I know it can vary for each person, but let's say for you.
So week 2, I'm working on range of motion on the table. So things like that, getting swelling down, maybe some soft tissue work to improve that. I'm doing open chain, ankle strengthening. So that's either, could be with my hand or a band. Dorsiflexion, like all of the planes, staying out of our painful range, combining dorsiflexion eversion. I'm progressing into closed chain. Calf
That's at week 3. That closed chain, I guess roughly for you, would that be?
I say you could, if they're coming into the clinic walking and stuff like that, and it's a 3 out of 10 pain, like that's going to be my guide, right? Of how we're progressing, stuff like that. I'll start that if they're like, yeah, I can do, a calf raise, 3 out of 10 pain, or maybe they're not going up as high. Maybe it's just like a pulse, right? Like, all right, let's stay there. Like, let's live there, right? So I'll progress some of that closed chain stuff week 2, week 3 of like just general calf raises. Maybe I'm adding a slant board to improve range of motion and things like that. Throwing the BFR cuff on them early and often. I think that is super huge, especially in those first few weeks. I mean, even throughout rehab, they're going to be getting it almost every time, probably every time with me if they see me, because you're able to load at such a lower, load, and it's going to help with pain. That's the biggest thing. Pain is going to shut off our muscle function. So yeah, like week 2, early range of motion, open chain, progressing to closed chain, week 2-ish, week 3. That's going to look varied between double leg work, single leg work, things like that, heel float positioning. Week 4, kind of the same, depending on how they're looking and things like that for your typical lateral ankle sprain. Maybe we're doing a little bit more of, anti-inversion or positioning like that on a slant board to make sure they're not rolling into that position. So having some, big toe contact on the ground, things like that. And then progressing, with more, eccentric stability in a heel float position or force, absorption type stuff. And then after that all goes well, then, seeing where they're at, seeing where their strength, their strength testing is, whether it be on a tin deck, which we have in the clinic. And that just allows us to see ankle strength, right? You can hook it up in certain ways, whether it just be plantar flexion, dorsiflexion, stuff like that. I am big on the numbers and things like that. I want them to be, as close as possible, but also understanding, seeing how they're looking like in our exercises from a rehab standpoint, not getting too stressed on like whether it's 85% or 95% just yet from the things that, I want to do from a running and cutting standpoint. Like, yes, we need to make sure we're adequately strong and things like that prior to doing that, because then you're just going to put the athlete at increased risk of injury if you're not testing. And Dan and I talk about this all the time. So those first 2 weeks, basic, get the swelling down, throw them in recovery boots, BFR, open chain stuff. You can even work on like quad and hip while you're there as well, if their ankle is really gassed. Working to discomfort, so like 3 out of 10 for me is pretty good. Maybe a 4 depending on if it's achy or sharp, but don't want to go past that, because then we're doing more harm than good type of thing, and progress based on tolerance and, and things like that. And obviously like the 24-hour rule is big for me too, right? Like maybe they're fine and the clinic feels good. They go home and it's like, it's a little aggravated. All right, now I know we did slightly too much. Let's back it down a little bit and go from there.
I think I would progress someone very similarly to the way you just outlined. I really like to avoid the pain provocation. I also like to avoid the effusion. Like if it gets real puffy after activity, I know I need to back it down. I also really like to consider like the difference in physiology here, right? Like if I get someone, post-op ACL, for example, like I can blow up their quad with hundreds to thousands of reps per day and get a real good response. I might not be able to do that at the ankle. And I mean, if volume solved everything, then John's calves wouldn't be as small as they are right now.
This is true.
So keeping that in mind too, right? Like I believe in the foot and ankle, this is the only area in the body where we actually have second-class levers, where we actually work at a mechanical advantage. So if I have mechanical advantage, then me doing like single leg body weight is realistically less than that. So I might have to load them more in the mid stage of rehab here to really elicit a good strength response. And this is an area where I think the safety squat bar really enters a strong, point in the chat here, because I can put hundreds of pounds on someone's back and we can do, we can hold. So the balance element is out, like a Hatfield variation that way. And we can hammer away at single leg, isos. We can do eccentrics. We can do that on a slant board. But I really think that actually loading the structure enough to get it to the point where we can, actually like see some positive change, not just get them back to where they were before, but get them back stronger and maybe better and maybe prevent this from happening again. I think that building, a bigger engine to a certain extent, or just bulletproofing it with more strength, is certainly a key element on top of that neurological, like motor control type piece. You touched on the blue foam. I'm notoriously against blue foam for most of my patients, because to me, I want them to feel the ground and improve their ability to react to what's underneath it. I want increased proprioception. And from what I remember, we use blue foam to remove that. And if I want to increase proprioceptive input to something, removing it doesn't really make a whole lot of sense to me. And you can make the argument, well, the athlete might need to rely on their visual and vestibular systems for balance more. And that might be true, but I can't think of a moment where, the athlete's foot is not on the ground when they twist it down and in like that. So, hot take on my end, but I tend to avoid a lot of those weird surface type things in favor of more of the heel float, the slant board type things you outlined. I also really like the band pull as well. So I like to put a band in different spots, maybe around the foot, maybe around the ankle, and actually pull them one direction or another while on one leg to try and see how they respond to, a force pulling them one way or the other, more than just like body weight on a slant board. And I think this is an area too where you can get creative with your movement patterns, right? Like, I could take a single leg RDL and modify that 50 different ways for someone, between floating the heel, using a slant board in there, or even just how I give them the weight, right? Maybe we use both hands, maybe one hand, maybe it's ipsilateral versus contralateral. Maybe we add some rotation on the way down or the way up. Maybe we use a band and that band is pulling them forward, or maybe that band is kind of wrapped around them like a backpack and it's actually twisting their trunk one way or the other. If I want to make it a little more sporty, I could, stick a lacrosse stick in their hands or something like that, so they feel like, this is something that's going to carry over to the field a little bit more. I think the possibilities are endless here, but I think it comes back to making sure you don't piss it off more, and you see slow trend better, that you load it enough to get the response that you want from it, and that you ultimately get them to a point where they're hopefully a little bit stronger. We don't always have the numbers like before injury, but if we do, great, we can look at it. But ideally, I want them to tell me they feel stronger and more stable and better after we wrap up with them than before their injury, because I don't want this to happen to them again.
I think you touch on a good point, and I know that this is, took a dive into the weeds, but I think, right, like once that swelling is down, and it could be anything, whether it be an ankle or things like that, but once that's down and you're a good few weeks out, if they're not strong, that's almost when you start seeing that pain continue because they just don't have the stability to support themselves in whatever position they're in. So you build, like Dan was saying, build a bigger engine. Like strength is damn near the name of the game. If you can get them as strong as you possibly can, that sets you up for success when it comes to, right, whether we're doing plyo progressions and then a return to run and then a return to sprinting or a change of direction. Because if you don't have the strength, you're not going to be able to do that. And so many times I've seen it where it's, whether it's athletes coming into us after, going somewhere else or doing stuff on their own or in general, and they're underloaded in the beginning, it's like you're not going to have a strong foundation to progress anything from there. So yeah, like Dan said, take into account your tissue healing times and severity of the sprain, but making sure that we're not making it more angry than it already is, calming it down and building strength and load and proprioception appropriately based on how that athlete presents.
Yeah, to touch on Dan, the RDLs are one of my favorite exercises. And, when we look at, we haven't touched on this yet, but postural sway and ankle sprains, right? And we know that there's an increased correlation between patients have more postural sway, that they can have a higher incidence of ankle sprains. So, focusing on those RDLs, right, and getting that core work in is extremely important. And, touching base, with your point on variations of that, which is great, because, if you have a 50-year-old patient who's, got some ankle sprains and maybe we want to do some core work and some RDLs, but of course they're scared or they don't have the flexibility. Maybe there's some variations that they could do as well with getting some rehab and getting their ankle better, but also getting their posture and their core good too. So yeah, RDLs, you said RDLs are like my favorite exercise personally.
And it's so easy to scale, right? Like if we need to, like if balance is the issue, I can have you hold on to something. If I need to load it more, I can load it more. Or if I need to go like hybrid where it's like, hey, I need a little bit more of a balance, but I still want to load it, like the landmine enters the chat. And it's like the perfect combo of both. So
it can be an intimidating exercise, single leg. It can be intimidating for some people that aren't in the gym a lot. But if you can modify it, like you said, it definitely can benefit the patient.
Yeah. I mean, really, I don't feel like, at least from past conversations with Jon, I don't feel like the two of us really do anything earth-shattering or revolutionary. It's a lot of the same basic movement patterns. It's just how you modify it for what they need or what they can tolerate in the moment.
Right.
Yeah, and as well as a different stimulus. It's not reinventing, like the wheel out here per se. Understanding our principles, what structures do we want to load? How can we load them with those activities and making sure that athlete feels it there? I think that's another big thing, making sure they feel it where you want them to feel it, what muscle should be working, etc.
I feel like we've covered a lot of ground, but Justin, I do want to hear, I know you've done some ankle ligament reconstruction and Brostrom procedure and that sort of thing. And I do want to make sure we bring that up before we kind of wrap up here.
Sure.
Can you just give us a quick rundown on that?
Yeah, we know that to an acute lateral ankle ligament repair, we just don't do that surgically, right? Because the research shows that therapy, a lot of things can help these patients, so we just don't do that. The ones that we do are those high syndesmosis ones, right? Those ones are frequently repaired acutely, and you hear about that, with the NFL, with the college players, getting that tightrope put in and back on the field in 2 weeks, which is still early, but I've done it on some patients, on a dancer, we did one. It was acute, it was like 1 week out, but you have the MRI there because it's bad. You just know that there's a lot of injury and inflammation and widening there. You got to get that back together. But as far as like a lateral ankle ligament, ATFL, we wait, right? I mean, most people don't need the surgery. The issue is, when they have chronic ankle instability, the ATFL, it's a intracapsular, ligament. So it's deep in that ankle joint. And what we find is that many times if it's torn completely, they'll get synovitis and just gunk in the lateral gutter. They'll get impingement. they'll get soft tissue impingement. So not only will they have instability, but when they go through range of motion, there's tissues that are getting caught in that lateral gutter. So many times we scope them, right? So sometimes what we'll do is just scope, just clean out. Maybe that can get rid of some of that impingement. Sometimes we'll go after that ATFL ligament too. We'll reconstruct it. We'll do a brostrum. It does well, but of course, therapy important too, right? We still got to get them better, get their perineals firing. But yeah, for the surgery, it's there. Of course, there's risks of surgery, right? It doesn't mean that they're never gonna sprain again. They could still tear it again, but it's there. We had a patient. She was an ex-gymnast. She was in her 30s. Her ATFL was gone, but it'd been gone, blown out, torn for a long time. But the problem is when you get chronic ankle instability, it puts more strain on other structures. And when you lose that level of protection, right, the next level is the perineals to try and protect you. And then next thing you know, you get perineal partial tears. And then the next level's, sometimes a fracture. And so that patient, she broke her right fifth metatarsal from an inversion sprain. So what we did was we repaired the broken bone, but while we're there, we're like, well, let's just repair your ligament too, because we don't want you to sprain and actually it become a fracture. So, we do them, but yeah, again, they're not done on acute, ankle ligament tears, right? And, they do provide some stability and patients can do well, but again, even after surgery, they do need rehab. And
yeah, it's not a quick magic fix, get back to the field in a week every time, huh?
Right. Now, most recently, soccer player, high school, syndesmosis repair. 4 weeks, we pretty much had him doing all close kinetic chain, single leg stuff. We wanted him just to go, right? After 4 weeks, for me, I'm comfortable with them as long as, pain level is low to start to do a lot more. That 4 weeks, I'm always a little cautious, trying to protect them and immobilize them. And, range of motion exercise is fine, but nothing high impact. But after 4 weeks, I usually give the therapist free rein to do whatever they can based on what they can tolerate.
Yeah, for sure. I love that. I feel like we've covered a lot of ground today as it relates to the ankle sprain, from just how it happens to the differential to examination, rehab, and even when surgery might be thrown into the picture there. Is there anything we missed today, or any closing thoughts or closing remarks either of you have?
My question for you all is when do you want these patients referred to you? They come to our office and earlier the better, or does it depend on the level of athlete? Does it depend if they're 50? Like, I'm sure you all get some referrals a month after a sprain, but when, and we know that manual therapy and a lot of those other modalities that you're using will benefit them. So what, patient comes into, okay, college athlete comes in my office initially. I'm sure they saw the athletic trainer first, but let's say they're summer break and they're actually not at school and they sprain, and I'm assuming you want them immediately, correct?
At least for me, as long as it's not fracture, I try and get them in as quickly as I can, just to at least get the ball rolling.
Okay.
And I also think that education is a huge important piece here. A lot of people that I've worked with, patients, clients, whatever, that way, if I don't kind of educate them on my process and stuff, they go to Google and they find things and they start doing things, and maybe those things are great, and maybe those things add salt to the wound. So I would rather just kind of like, hey, this is what I see, this is what I think is going to help, here's why, as opposed to preventing like the PubMed Ranger from kicking in, so to speak.
Yeah, no, I agree with Dan. I want them in right away, just because are things that we can start working on and stuff like that. We actually even had one individual who ended up having a fracture. It was a Jones fracture from an ankle sprain. And they came into us. Obviously, they were put in some form of mobilization, like limited weight bearing, based on what that doctor referred. But we worked on other things, right? Throw the BFR cuff on them. We're, doing things like that. They weren't going to be in it for too long. So there's always buckets that can be filled and things like that. Obviously, if you have a more long-term, weight bearing, issue that you can't have, or weight bearing restriction, we know atrophy is going to set in quick to other structures. So we're doing our best to help manage that and educate that patient on that, because a lot of times they don't know or things like that, or they're not sure what they could work on during that, let's say, waiting period if there is a restriction, but usually right away.
A lot of my colleagues, we don't know. Sometimes we're like, wear this boot for 2 weeks. Here's some, do the alphabet, right? The alphabet with your foot, and then I think you'll be good, and sometimes that's a disservice to the patient.
On that too, depending on the health insurance plan, or some patients have even just bought them out of pocket. I do like to order the NMES device for people at home. And even if it's just simple, like, hey, we can only do open chain right now, but hey, you can stim the heck out of this muscle, this muscle, this muscle. Here's how you set it up. Here's how you do it. Here's what I want you doing, exercise wise with that while you do it. Like, I do think there's value in just keeping things like quote unquote alive, as opposed to just kind of sitting around and not really doing anything. And I think that the NMES makes a better case from a strength and just overall recruitment standpoint than just straight active range of motion. Agreed.
And for whatever reason, other than the quad, it is one of probably the most underutilized things. Like, we think about, quad, stim. We forget about like other structures, rotator cuff or scap, or helping patients got, an issue with shoulder stuff. Maybe they don't have low trap activation, and they can't feel that, let's put it on that so they can, I got it. You know what I mean? So that's just a super underutilized tool, and understanding the basics of hypertrophy, right? Like maximum motor unit recruitment. Well, what's going to help me get there in a lesser state input? So if you can't load, stim, BFR cuff, and all those things. So that was a good point, Dan.
For sure. For people who want to find out more about the two of you, whether that's, online or see what you're doing clinically in person that way, where can they find you at?
I have offices in Eldersburg, Maryland, practice primarily out of Carroll County, Maryland, and then we have a satellite office in Shrewsbury, Pennsylvania. That's where you can find me. Office number 410-795-2155. Instagram, Justin Lewis _foot surgery, where you can see a lot of my work with some athletes and some surgeries and other things that we do.
You can find me on my Instagram, diamond, as in like an actual diamond _ Dr. DR14. You can message me on there, or shoot me an email at jharned, HARN as in AED at truesports.com. Usually Instagram's the best because, I'm on it for work and stuff like that. So I have a high amount of like rehab videos on that, just from an educational standpoint. But, a cold DM is always good.
For sure. We'll link to that in the description below too. That way, if people didn't quite catch it, they can just check there. Really appreciate you guys coming on today. Thanks for everything.
Thanks for having us, Dan.